Do lifestyle interventions or daily metformin really reduce multimorbidity in adults with prediabetes? Can artificial intelligence help in the management of diabetic macular edema? For infants with bronchiolitis, does prone positioning prevent escalation to higher levels of respiratory support? This and much more on today's JAMA Editor's Summary. Hello, and welcome to our listeners around the world. Today is Thursday, June 18th, 2026. I'm Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network. Today, I'm joined by JAMA Deputy Editor, Dr. Preeti Malani. Let's jump straight into this week's research. So I have the first. For adults with prediabetes, we know that preventing not only diabetes, but also related comorbidities is essential for healthy aging. In a 21-year observational follow-up study by Dr. Saliv and colleagues from the Diabetes Prevention Program, or DPP, research group, investigators tracked over 1,000 U.S. Medicare participants with prediabetes. These participants from the original DPP study were randomly assigned to either an intensive lifestyle intervention, metformin, or placebo. The lifestyle intervention focused on reduced calories and fat, as well as 150 minutes of physical activity weekly. The team in this study specifically asked whether these early interventions could reduce the risk of chronic diseases like hypertension, kidney disease, COPD, depression, and others later in life. At the end of the 21-year follow-up, 85% of participants had developed at least 2 chronic diseases, with a median number of conditions at 5 per person. The risk of developing multimorbidity was 21% lower in those in the lifestyle intervention group compared to placebo. But there was no difference in risk seen between metformin and placebo. So, based on this study, for adults with prediabetes, a sustained focus on healthy diet and exercise remain powerful tools for curbing the domino effect of chronic diseases as we age.
Thanks, Kirsten. That's compelling data from an impressive longitudinal study. In an accompanying editorial, Dr. Flores and colleagues put these findings into a broader context, framing the multimorbidity crisis as a key challenge for healthy aging and one that demands robust, scalable prevention. The editorialists emphasize that while lifestyle interventions work, we need dedicated infrastructure and coverage to deliver lasting behavior change, especially for older, underserved populations who may be at higher risk. They also highlight that this benefit was not seen for metformin, and while the door remains open for newer drug therapies, diet and exercise is still the core. Prevention pays off not just for diabetes, but also for the broader problem of multiple chronic illnesses. Our next original investigation touches on the growing importance of AI in medicine, this time for diabetic macular edema, or DME, which is a leading cause of vision loss among adults with diabetes. Screening programs commonly use retinal photos, but those can have a high false positive rate, meaning many people get referred unnecessarily for confirmatory testing. This can create burdens for both specialty clinics and patients. In this prospective trial conducted in Hong Kong, Dr. Xiong and colleagues tested whether an AI-powered optical coherence tomography, or AI-OCT, can be integrated into real-world diabetic retinopathy screening to help triage patients for DME. After validating the system in more than 600 patients, the investigators conducted a randomized trial. 276 people with suspected DME from standard screening were either referred for specialist evaluation based only on the photographs or using the AI-OCT to help refine referral decisions. The key finding was that using AI-OCT decreased unnecessary referrals from about 69% down to 24% without missing true disease. In fact, no cases of DME occurred among non-referred participants in the AI pathway. The authors suggest that integrating AI-OCT as a second step after photo-based screening could meaningfully reduce unnecessary eye clinic visits, freeing up resources and saving patients the time and expense of clinic visits without compromising safety.
As more AI-enabled tools proliferate, it's critical to have rigorous prospective trials that look past just test metrics and focus on what happens to care and downstream referrals. So let's switch gears now from adult outpatients to hospitalized infants, in this case with a study in acute bronchiolitis. Prone positioning has shown some benefits in adults with acute respiratory failure, but its utility in infants with respiratory distress is less clear. The Propositist randomized trial led by Dr. Bowden and colleagues enrolled 451 infants with acute bronchiolitis, ages 6 months or younger, across 15 French hospitals. Infants had moderate to severe respiratory distress requiring high-flow nasal cannula and were assigned to prone versus the usual supine position during the first 48 hours of their stay. The primary outcome was escalation to higher levels of respiratory support within 72 hours. Escalation occurred in about 18% overall, 15% in the prone group, and 21% in the supine group, a difference that did not reach statistical significance. Serious adverse events were extremely rare in both groups. So, prone positioning did not seem to significantly reduce escalations of care for infants with moderate to severe bronchiolitis. However, it's important to note that a large proportion of infants in the study were not able to complete the proning intervention, something the investigator did not anticipate, and a factor that may have limited the study's ability to identify a significant impact for the intervention.
Thanks, Kirsten. Sounds like the study doesn't settle the debate, but suggests that routine use of prone positioning in these infants should not be the standard until further research is available. Next up, a question for oncologists. When patients with EGFR-Variant non-small cell lung cancer progress after receiving tyrosine kinase inhibitors, options are limited, and overall outcomes tend to be very poor. Will a new approach, a biphasic antibody called Ivonescimab that targets both PD-1 and VEGF, extend survival when added to standard chemotherapy? The Harmony A phase 3 trial addressed this by randomly assigning 322 patients in China with locally advanced or metastatic EGFR-Variant non-squamous, non-small cell lung cancer who had received prior EGFR tyrosine kinase inhibitors to chemotherapy with or without Ivonescimab. Over a median follow-up of more than 32 months, adding the antibody improved median overall survival from 14.1 months to 16.8 months, a 2.7-month absolute gain. The survival curves separated early and stayed apart at 2 years and beyond, with 30% of patients alive at 30 months in the Ivonescimab group versus 18% with chemotherapy alone. Importantly, about 2/3 of patients receiving Ivonescimab experienced severe treatment-emergent adverse events, compared with just over half in the chemotherapy alone group. Bottom line, Ivonescimab plus chemotherapy produced a statistically significant survival benefit in this challenging-to-treat lung cancer population, although the absolute difference was modest.
That is a step forward for this population where prior immunotherapy combinations have failed to yield clear survival gains. As the treatment landscape keeps evolving, this study provides another validated immune-based strategy to consider in patients who have experienced progression on EGFR TKI therapy while weighing benefits and risks carefully. Let's turn to 2 research letters that relate to distributions of healthcare resources in the U.S.
Sure, Kirsten. In their letter, Dr. Ramesh and colleagues evaluated the impact of some recent legislative attempts to address geographic and specialty-specific physician shortages in the U.S. The laws aimed to add 1,000 new Medicare-funded graduate medical education slots. Although the laws aim to boost placements in rural and primary care specialty, only 2 to 6% of the new slots actually went to rural institutions on any given round, and that proportion dropped over time. The proportion of new slots designated for primary care also fell over time. The upshot? These federal expansions may not be closing the urban-rural gap or addressing the primary care shortage as intended. The authors write that more targeted policy action likely is needed to truly address these distribution issues.
Another research letter by Drs. Olensky and Werner examined U.S. nursing home closures from 2016 to 2025. Despite worries about mass closures during COVID, actual closure rates stayed stable overall, about 1% per year. But access shortages have worsened in rural regions. Almost 29% of nursing home closures led to areas with no nearby alternative or adequate capacity to absorb displaced residents. Closures were more frequent among low-quality or nonprofit facilities. While pandemic-era financial support was linked to fewer closures, the authors highlight an ongoing tension between striving for higher standards and preserving access to care, especially for patients in rural nursing home deserts.
Now let's take a look at some new viewpoint and perspective articles. One of this week's viewpoints tackles the rapidly expanding online market for illicit injectable peptides. These synthetic peptides are widely promoted on social media for body enhancement and anti-aging, and Dr. Pietkowski and colleagues highlight the regulatory confusion in U.S. drug policy. Peptides straddle the line between compounded drugs, wellness supplements, and illicit products, outpacing the U.S. FDA's ability to monitor and enforce. The authors call for stronger federal oversight, coordinated digital platform enforcement, and better research to track harms, especially as influencer-driven use grows among young people.
In another viewpoint, Dr. Chin and colleagues tackled the issue of amyloid PET imaging. As amyloid PET imaging expands to evaluate cognitive impairment, these authors advocate for using quantitative Centiloid values rather than sticking to a simple positive-negative read. The Centiloid scale provides a numeric estimate of global cortical amyloid plaque burden. The authors in this viewpoint argue that reporting a numeric value better captures disease stage, helps guide therapy, and improves shared decision-making. The binary approach, by contrast, compresses a continuum and misses valuable cues for prognosis and patient counseling. These authors argue precision memory care means moving beyond binary results and interpreting the whole clinical context. Now, let's close with some clinical pearls for clinicians and patients. Low back pain remains the leading cause of disability worldwide and one of the most common reasons people seek care. Here are key points from a new comprehensive review by Dr. Cashin and colleagues. About 90% of back pain cases are nonspecific, not caused by herniated discs, infection, cancer, or other specific diseases. Risk factors include older age, obesity, depression, occupational strain, tobacco use, and other chronic illnesses, and a history of prior back pain. Most low back pain gets better on its own, with about 70% recovered at 12 months, but chronic pain is less likely to resolve. First-line management is reassurance, education, advice to stay active, and supporting self-management. Prolonged rest should be avoided. For acute pain, superficial heat, spinal manipulation, massage, acupuncture, NSAIDs, and skeletal muscle relaxants offer short-term relief. For chronic pain, structured exercise, psychological therapy, and integrated multidisciplinary care are the best evidence-based options. Medications for chronic pain are second line. Opioids, spinal injections, and surgery should be rare and reserved for severe refractory cases. Here's a bit more about medications for acute low back pain from this week's JAMA Clinical Reviews podcast with review co-author Dr. James McCauley.
Medicines are usually regarded as second-line care, and NSAIDs can provide small benefits to patients, although obviously we need to be aware of the adverse effects. Muscle relaxants such as tizanidine may provide short-term symptom relief, but they're often commonly associated with sedation. There are common treatments that are not supported by the evidence, so it's useful to talk very quickly about those. Acetaminophen alone doesn't appear to be effective for acute low back pain, and I think this is a result of a trial that was published in the mid-2010s. That's only on the basis of one trial, but all guidelines now suggest that acetaminophen is not effective on its own for low back pain. Benzodiazepines should be avoided, and the recent OPAL trial also demonstrated that opioids were not effective compared to placebo when added to guideline care. They also increase the risk of adverse events, and later increased by a small amount opioid misuse.
There's a lot of great information in this review and podcast. It's a good refresher for all clinicians. Some of the key takeaways to this discussion: remember to evaluate for red flags, minimize unnecessary imaging, and focus on helping people return to their usual life.
We also have a new JAMA Insights article on vibriosis. A quick reminder as the summer heats up, vibriosis, due to non-cholera Vibrio species, is on the rise in the U.S. coastal regions. Most cases occur from eating raw shellfish or exposure of wounds to brackish water. Illness can range from self-limited diarrhea to necrotizing skin infections and sepsis, especially in people with underlying liver disease, alcohol use disorders, or those who are immunocompromised.
Does AI change clinician behavior, improve patient decisions, or simply create a convincing performance of intelligence? In this week's JAMA Plus AI podcast, Yun Liu, a research scientist at Google Research, speaks with JAMA Plus AI Associate Editor Yulin Schwen about what is behind the curtain in these AI systems.
And in this week's Healthy Dialogue podcast episode, JAMA Senior Editor Dr. Derek Angus discusses the rise in early-onset cancer with JAMA Associate Editor Dr. Kimi Eng and JAMA Internal Medicine Assistant Editor Dr. Ilana Richmond. Here's a bit of their conversation.
We will make advances in our understanding of why this is happening, as well as how we can better treat our young patients. I think in the meantime, it is still really important to, one, get screened if you're eligible to get screened. Two, it's still important to follow a healthy diet and lifestyle, as Ilana was saying, because even though I mentioned that so many of our patients do and they get diagnosed anyway, it is still really important to follow those healthy habits starting from early childhood. And three, and we didn't really touch on this a lot, but I think many people don't know their family history. And so it is really important for primary care doctors to ask, for people to talk to their family members about whether there is a history of colorectal cancer, for example, or colon polyps, because that could change the age at which you begin screening and could be potentially life-saving.
And as always, there's a lot happening in health news. Be sure to listen to the JAMA Medical News podcast, which publishes every Friday and gives our listeners insight into the latest medical news. You can subscribe at jamamedicalnews.com or click on the link in this episode's show notes.
That's a wrap for this week's JAMA Editor's Summary. Thanks, Preeti, and thanks to our listeners for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Kirsten Bibbins-Domingo. This episode was produced by Shelley Steffens, Dr. Michael Lipnick, Dr. Krista Roberts, and the team at the JAMA Network. A link to this JAMA content can be found in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.
The script for this podcast was generated with assistance from GPT 4.1 OpenAI tools following an editor-developed prompt. The script was then reviewed, edited, and approved by editorial staff. This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.